Okay, perfect. Well, I think we should start first of all with some introductions. So, as you both know, my name's Elisha, and I'm the program director for the 4th Annual Longevity Therapeutics Summit, which is happening June 28th to June 30th in San Francisco. So, super exciting. And today I'm here with Michael. If you want to introduce yourself first.
I'm actually president of Telocyte. I got involved in aging research about 50 years ago, actually. I gave the first talk at NIH on this 26 years ago, the first medical articles on it, wrote a textbook about it. And now I'm finally getting my fingers dirty and trying to take this to human trials, which is, of course, where I ran into John. My background is an MD and a PhD in this area, but it is dearly important to me. In fact, I'm writing another textbook on it for Elsevier Publishing. But still, as I like to stress, the important thing is the clinical data, not the textbooks. John?
Well, first of all, thanks, Elisha, for inviting us to present on this topic. And Michael, thank you for inviting me to be your co-moderator in this exciting session that we have planned on longevity. And I'm professor and chair of the Department of Cardiovascular Sciences here in Houston Methodist Hospital in the Texas Medical Center. I'm cardiovascular doc, cardiovascular biologist, been interested in cardiovascular senescence for many years, and particularly most recently on the role of telomere erosion in senescence.
Okay, great. Well, thank you so much, guys, for joining me today. So I had prepared a few questions for our interview today. And the first one is, why do we think that 2022 is such an important year for the longevity therapeutics field?
I guess I'll start on this, but sometimes John should too. I don't mean to take first every time. I think one of the things we're finally getting in this field is both credibility and funding. As I look back, if I go back 20, 30 years, there was a great deal of snake oil involved and a lack of credibility and rigor, I think. And that is not only gradually changing, but I think people are realizing that. And again, not only within the scientific community, the medical community, but within the funding community. So funding is increasing. And I see 2022 as giving an example of that. The other thing is, underlying this, there is a changing paradigm, which is instead of thinking that we really cannot intervene in age-related diseases other than symptomatically, we're beginning to realize that it's possible to have feasible and effective clinical interventions at a most fundamental level, cell aging, for example. So that changing paradigm has opened up a number of venues for us in terms of clinical trials, as well as beginning to get the respect of funders, VCs, for example, big pharma, for example. So things are changing. John?
I would fully agree with what Michael said. I would add to it, 2022 is the year that we emerged from the pandemic. And I think we owe a lot to this new emerging field of RNA therapeutics in the emergence from the pandemic. After all, the mRNA vaccines did help us to achieve resistance to the virus. But it brought attention to this emerging field of RNA therapeutics that has tremendous promise. And I think deployed toward longevity, the opportunities are almost limitless for RNA therapeutics. A new tool in our armamentarium toward enhancing longevity.
Yeah, I completely agree. And on our kind of the point of VCs kind of paying attention to this field, it's really exciting because we actually do have a panel of VCs this year. So I think it's a really good opportunity to kind of understand a bit more of how people invest in longevity, like how they make those decisions, why they invest in longevity. But yeah, so going on from that, so obviously this is a really important year for longevity therapeutics, but what do you think the future of longevity therapeutics is?
John, you take first this time.
Well, I think Michael already has told us that, there's a lot of opportunities in various aspects of aging. I think we're coming to the conclusion that aging is multifactorial, that there are, many causes underlying aging, that we all age differently. And in some cases, some of those processes that are involved in aging are more dominant. And, I'm speaking of things like mitochondrial dysfunction, genomic mutations, stem cell exhaustion, abnormal intracellular signaling, impairments in proteostasis, and telomere erosion also are causes of aging that need to be considered. Abnormal intracellular signaling, the senescence-associated secretory phenotype. So I think there's different approaches to each of those processes. I think we need to keep that in mind as we go forward, because a multifactorial approach to aging is going to be one that is probably going to be most successful.
I would like to build on that in a slightly different direction, which is to suggest that it may be that many of these are related. So, for example, telomere erosion may play a role in the underlying changes in mitochondrial dysfunction with age. We know, for example, that our mitochondria and eukaryotic organisms have been around for probably almost 2 billion years, depending on who's making the estimate. And we did not inherit aged mitochondria at fertilization. We inherited perfectly functional ones. And yet they're not perfectly functional, most of us, after several decades of aging. So, and that may again be linked to changes in telomere and epigenetic changes. And so overall, I think what we need to do is try to understand aging, not only in a unified sense. Yes, it's multifactorial, but are there some common models here that can explain how things work together? But the other thing I often emphasize is that I'm not interested in some sense in what causes aging. And I say that in a sense to be provocative. What I'm interested in is where's the optimal point of intervention clinically and financially. Now, as I used to say to my students, my medical students, the patient didn't come in for a diagnosis, they came in for treatment. Now, it is true that often you need to make a diagnosis and understand the disease in order to treat them. But the point is practical outcome. And I think that's true here. The question is not, from my mind, what causes aging, because to me, that's sort of an interesting philosophical academic question. But as a physician, and I think John gets me here, the question is, what can we do about it? Is there something we can do clinically that is safe and effective? And that, I think, is part of the changes that are going on in longevity therapeutics. The understanding that we're beginning to get is that there probably are effective point of interventions. Now, to do that, again, we need to understand the kinds of things John is talking about, the kinds of things I'm talking about, but that is not the end. That's simply the beginning, or the basis on which we can move ahead with practical interventions.
Okay, that's really interesting to hear. And what do you think the biggest challenge is right now in the longevity field that is kind of halting the progress that we want to see in the future?
Well, one challenge, Elisha, is regulatory. The aging is not recognized as a disease process by the FDA. That should change, because all of the major causes of morbidity and mortality in the world are really aging-related diseases. So cardiovascular disease is an age-related disease. Age is the biggest predictor for cardiovascular events, major adverse cardiovascular events, heart attack, stroke. So aging needs to be considered as a disease process. And when that's done, I think from a regulatory standpoint, that will clear the road for new therapies directed toward reversing aging.
Yeah, I like to quote my friend Len Hayflick, who says that, everybody would agree that the major predictive risk factor for age-related disease is aging, as John says. But most people then ignore the aging process and move on to what are essentially signs and symptoms. That is, for example, cholesterol deposition, aortic aneurysms. And those are important, but the question is, what do they have to do with aging in the first place? And we tend to ignore that issue. So we need to go down a little further and get a better grasp on that. Now, as far as aging being a disease, I can look at it in 3 different ways. One is the biological concept, which is it a disease or not? Well, it's clearly a dis-ease, but whether you sort of decide subjectively to call it a disease or not is, in some sense, academic. But then there's a social aspect, and I find that when I talk to many physicians or biologists, they will tell me it's not a disease while they're dyeing their hair and getting Botox and trying to deal, that is, their actions act like it's a disease, although they're denying it intellectually. That also sort of doesn't concern me. I find it interesting and amusing, but not relevant. The third, though, is the point that John has raised, which is the regulatory component. Now, the NIA back 25 years ago had a private white paper internally saying we will not consider aging a disease. We'll take aging diseases, but you can't come in with an indication for aging only for age-related cardiovascular disease, for example. And I think that is changing. It clearly is changing. But it still is, in some sense, a regulatory roadblock, at least to an extent, because it's a conceptual roadblock. Practically speaking, we still need to be able to measure outcomes, surrogate outcomes, biomarkers, we need to be able to measure something. We can't just say aging without defining what it is we're measuring, whether, as John said, it's mitochondrial dysfunction, whether it's wrinkles, whether it's age-related neurodegenerative diseases like the dementias, whether it's osteoporosis, bone mineral density. We need markers, because otherwise, as we've all known, if you can't measure it, it's not science. But it's also true if you can't understand it, it's not science. It's not simply enough to measure it. You have to understand what it is you're measuring and why. So again, I think we need to understand the aging process. And as John has pointed out, I think the regulatory environment is changing, but has a ways to go.
That's really interesting to hear. And it's good to hear that you think the regulatory climate is changing. What makes you think that? And what kind of steps do you think are happening to change these challenges and overcome them right now?
I think we've got, I think of 4 major challenges. I just chaired a conference on gene therapy, so a lot of this translates quite well from it. But the first of the 4 challenges is technical. How do we actually do things? And the technical landscape and our technical abilities are changing rapidly. John knows this with regard to mRNA. The same thing is true with specific gene therapy, for example, viral vectors, what serotype, which virus do you use, what about the plasmids, what about the interactions? These things are all in rapid flux. So there are technical challenges right now, the biggest one being that whatever we're using now is not what we'll use in 5 or 10 years. Things are changing very quickly. The second is the funding or commercialization issue. With regard to gene therapy, the problem is if you focus on just a rare disease, John and I have talked about progeria, Hutchinson-Gilford progeria, and if that was your only indication, there aren't a lot of patients out there to amortize off the R&D costs. Whereas if you're dealing with age-related cardiovascular disease, it's a different model, and the funding is changing. As I say, the investors, the VCs are beginning to get a little more sophisticated about longevity therapeutics. The third one is a conceptual change. That is our understanding not only of what aging is and why it's important to understand aging as opposed to outcomes, but the same is true with regard to, for example, genetics. In gene therapy, we often focus on genes. And if you're looking at protein encoding genes, you're only dealing with about 1.2% of the human genome, and there are an estimated 40%, probably more, of regulatory elements. And we tend to focus on the gene for hemophilia, the gene for sickle cell, the gene for spinal muscular atrophy, without asking ourselves, what about the regulatory components? So there's a whole new landscape out there waiting to be worked on. And the fourth major challenge that I still think is the biggest one is the credibility issue, because the credibility will be judged not on the basis of articles and funding and textbooks and conferences, though they're excellent. It'll be judged on the basis of clinical results, and that is changing. But we need to keep our eye on the ball and prove that what we can do is working. Otherwise, we're just back to where we were 30 years ago, with people using as essentially crystals and meditation to treat aging. And that's not treating aging. That may be useful, but it's not treating aging.
Did you have anything to add, John, or do you want to move on to the next question?
No, let's move on to the next question. I think Michael covered that well.
Okay, great. Well, I wanted to also ask, I know that you introduced yourselves, but I wondered if you wanted to share just a little bit more of what you both do in your respective roles. And also both Michael and John are joining us for talks and a workshop at the Longevity Therapeutics Summit. So if you want to give a sneak peek of what your talks will be about and your joint workshop, I think it'd be really interesting to hear.
Well, I'm chair of the Department of Cardiovascular Medicine here at Houston Methodist, and we've got a lot of activity going on. This is the house that DeBakey built. It got a great tradition in cardiovascular therapy. We've got great cardiovascular clinicians and surgeons. We have about 200 ongoing clinical trials in all manners of cardiovascular disease. But you know what? They're almost all age-related because most cardiovascular disease is age-related. So we have a very busy practice in age-related medicine, if you were to look at it that way. I also have a research unit. We have a Center for Cardiovascular Regeneration, where our intent is to make fundamental insights and translate those fundamental insights into something that's useful for cardiovascular health. My own laboratory within that center is focused on 2 things. One is what are the determinants of cell fate? And one of the things that's quite interesting is, maybe we'll talk about this, Michael, at the conference, is that aging is a change in cell fate. And changes in cell fate are really determined by epigenetic alterations that turn off or turn on genes that are involved in cell identity. The other area that we're interested in is the role of telomere erosion in aging. And we've got some wonderful data that I'll present at the conference, some new data that suggests, in fact, that Michael is quite right when he says that some determinants of aging may be more important than others. When we restore telomere length in senescent human cells, we are able to see improvements in a lot of the other processes involved in aging, including the mitochondrial abnormalities and abnormal intracellular signaling and the senescence-associated secretory phenotype, even mutations we can see reversal of. So I think I'm also looking very much forward to what Michael has to say at this conference. But that's a little bit about what I'll be talking about.
Yeah, and I think John and I will play well off each other in many ways because we have many of the same models that we're working with. As I say, I've gotten involved in this for now, well, a lot of time. And my emphasis always has been on, as I say, practical results. What can we do clinically? And the first article ever that showed we could reverse aging at the human cellular level was published now 24 years ago in Science, Andrea Bodnar's group out at Jern. And the same has been followed through in vitro with work on human tissues. And then there's been some other relevant data that looked at this, including some of the fair data on telomerase activation and so on. But then about 12 years ago, there was a paper out of Harvard looking at alteration of the germ cell, we can turn on and off telomerase. And then Maria Blasco's work about 10 years ago doing this with a viral vector. And then John's work, you can get mRNA. And in all cases, what we find is that we can essentially, as far as we can tell, within technical abilities, reset much of the epigenetic pattern. You know, the difference between a cell in my liver and the cell in one of my neurons is not genetic generally. I mean, there's some interesting things in the immune system, but in general, it's not a genetic difference, it's an epigenetic difference. It's the same set of instruments playing a different tune. But the same is true if I look at my cells at age 7 and my cells now at age 72. The difference is generally not genetic, it's epigenetic. It's, again, not the instruments. It's not that the violin is out of tune, it's that the violin is playing a different score. And the question is, how can we reset that score most effectively? And this is the kind of thing that John and I have been involved in. In Telocyte, what we're planning on doing is taking this to human trials, and our first strategic target is to go after Alzheimer's because it has two advantages for us. It is a fatal disease, and there are essentially no alternative treatments, aducanumab notwithstanding. And, there have been more than 2,200 interventional trials in Alzheimer's by global consensus have failed. And we think we can actually do better than that based on both the human cell work, the human tissue work, and the animal work in vivo. But that's a strategic target. But our second major target is one that John and I share a love for, which is age-related cardiovascular disease. So we're actually talking about a possible joint venture where we do some of the animal studies and get the data on cardiovascular as well as on age-related neurodegenerative disease. But in that sense, we share a very parallel interest because we think we can effectively intervene, if we're good at this and we're right, effectively intervene in diseases that have no prior historical precedent. It reminds me of the transition we went through over the past 200 years with regard to microbial theory. It was a conceptual shift that allowed us to do more for human good than anything else we've done in medicine. Not robotic surgery, not cardiac transplants, not the latest statin drug, all of which are useful. But the idea of microbial theory gave us an edge up in improving human lives. And I think we're about to go through a similar transition, maybe even more so, with regard to age-related diseases, which until now, we have never been able to intervene effectively at any fundamental level. Again, we have things for osteoporosis. We can replace your knee for osteoarthritis. We can try to put you on dialysis for age-related renal failure, but these aren't fundamental interventions. I think we can do a lot better, but we'll have to take it to human trials and see, both John and I.
I like that comparison that you made, that analogy you made, Michael, to the microbial theory, where we are now with longevity theory. And you're absolutely right. The 90% of the increment in the human lifespan has been related to improved nutrition, improved sanitation, and antibiotics. And then, we get another 10% with statins and the rest, which is great and useful. But most of what we have actually done is related to nutrition and infectious diseases. So now with longevity theory, I think like microbial theory, we can have a significant increment in human lifespan.
Yeah, let me give you two pieces of that in addition. One is, the classic example is hand washing at delivering babies, which drastically cut both the maternal and the neonatal death rates. And it cost almost nothing. Soap, lye soap in those days. But it was an enormous benefit. And while the latest statin is an improvement, this often goes along with an increase in the cost of medical care, whereas washing hands actually decreased the cost of medical care. Another classic example of that would be treating polio. In 1950, if you look through what was then paper articles on the concerns about medical economics, you found this recurrent theme that by the year 2000, many Western countries would be medically bankrupt because of the cost of treating polio victims. Iron lungs are expensive, rehab, braces, nursing care, pulmonary toilet tend to be expensive. And in fact, by the year 2000, instead of being medically bankrupt, the WHO estimates were that treating polio was less than 10 cents per capita. I think we're about to undergo the same sort of translation in regard to age-related diseases. We are now concerned about, for example, the in excess of $100,000 a year treating the last life of patients with Alzheimer's. And I think we're going to find that the cost of treating and preventing Alzheimer's falls down in the $5,000 range, give or take, rather than the $100,000 range where you're not treating it. So again, I think we look too narrowly at progressing in a sort of linear direction. Cost of iron lungs, we've got to get a better iron lung. And I think the same is true of age-related diseases. I am not knocking nursing care for patients in hospice and Alzheimer's, but I think we can do a lot better and cheaper.
I'm excited for your talks now. Thank you both so much for sharing. And I think my final question for you was, why is it so important for this community to come together in person again for the first time in 2 years? And is there anyone other than each other that you're really excited to meet at the conference this year?
Well, it's going to be wonderful to get together. There's so much that happens when you have people working in different interfaces coming together. Very interesting things happen at those interfaces. Sparks occur and insights occur that otherwise wouldn't happen. So as I mentioned, my focus is in cell fate transitions and telomere erosion. I'm interested to talk to people who are working in other areas of aging, and I mentioned a few of those. I think by interacting, by exchanging ideas, there's going to be some synergies that will accelerate the field moving forward.
I think John's right. In some respects, John and I know a great deal about aging, but I think we would both admit that if we go forward 100 years and look back, we'll realize that we only know 1% of what we'd like to know. And some of that increase in knowledge and understanding comes about by listening to people, other people around you, often who had very disparate views. So yes, there are a number of people, looking forward to seeing Matt Keberlein again and some of the investors, Anastasia and Carl, people that are going to be involved in this field. But there will be unexpected meetings with unexpected consequences, often quite beneficial.
That's great to hear, and I'm really looking forward to it. And I think you're right. The people that you meet at conferences can change your life. So yeah, thank you so much for joining us today. And I'm really looking forward to both of your talks and your workshop on June 28th. But yeah, thank you both, and look forward to seeing you next month.
Thanks, Elisha.
Thanks a lot. I hope you have a lovely day, and I'll speak to you soon.
I look forward to seeing everybody there.
Thanks a lot. Bye.
Bye-bye.
Bye-bye. Hey, John. Goodbye.